now we're going to talk probably about the most dramatic of all. What do you do when a patient calls you and says, I was just in an accident or I fell and my tooth was knocked out? What should I do? Now, if we're in a small group, I'd ask each one of you what to tell them to do. But I don't know if anybody has any thoughts. Okay. The best thing you could do is tell the patient to put the tooth back in. Now, years ago, we didn't tell them that. We used to tell them, at least a long time ago, we used to tell them to put it in a glass of water. And then we decided that, okay, water wasn't so good, but maybe you could put it in their mouth and let it be in saliva. So we would have a lot of kids that would knock their teeth out. We told them to put it in their mouth and keep it bathed in the saliva. It's amazing how many kids swallowed the tooth. Or they chew on it and the periodontal ligament is gone. Okay? So we don't tell them to do that anymore. So they started investigating different types of solutions. And in, let's see, it was not Norway, but in Sweden, Blumloff did some research looking at different types of solutions and found milk was the best solution to keep the tooth alive longer. And that still is, if you have somebody who can't put the tooth back in, is milk, unless you have Hank's Balanced Salt Solution. Now, Hank's Balanced Salt Solution, which is what this thing is, and it's at the top of the list, is a tissue solution. And it's to keep the tissue viable. We use it for tissue cultures. I don't know if you have it available here, but in the States, you can get something called a Save-A-Tooth kit. And in the Save-A-Tooth kit, there's this little plastic basket to hold the tooth, and it lets it soak in the Hank's Balanced Salt Solution. So that's what we're using, but the best thing is if the patient could put that tooth back in. Okay, so here we have a kid that came in, was in a fight, got one tooth knocked out, another tooth broken, and this one here was pushed inward. So probably the top of it was pushed outward a little bit. So when a patient comes in, first thing we tell them to do is put that tooth back in your mouth. Well, sometimes they don't, and they don't want to. Sometimes a parent is panicking and doesn't want to. Sometimes they're afraid they're going to put it in backwards, and I tell them, that's okay. Put it in back. I don't care if they put it in backwards. I don't care if they put it part way in. As long as it's up in there, that's the best solution you have. So I tell them to put it in. First thing that'll happen when they come in is if it's in there and not quite right, we'll put it back up or we'll turn it around. But if it's out, it's just going to dry up. Okay, so tell them to put it back in. When they come in, we want to clean the area. We also want to take a good history. Legally, you're going to need a good history with all, I don't know if you have insurance here, all the insurance information, what happened, when it happened, how long ago it happened, who was involved, because if there are lawsuits, and you know, since your law school here is getting bigger and bigger and turning out more lawyers, you're going to have more people suing people here. So be ready to get all that information on your records. And while they're doing that, your assistant could be cleaning the area with chlorhexidine, or you could be doing that while the assistant is getting the information. If the tooth has been out of the mouth for more than an hour, soak it in sodium fluoride. Sodium fluoride tends to work, tends to keep the resorption away. It doesn't always work. but it's the best thing we have. And I'll show you one that actually worked like that. Okay, so we have this guy who was in the fight. This is a patient that I used the sodium fluoride on. This patient had the tooth knocked out on a Friday, went to his dentist. He then, on Monday, went to his orthodontist, still without the tooth, and asked the orthodontist if they could move his teeth over. And the orthodontist said, wait, I have to make a phone call. And he called me and said, I seem to remember you giving a lecture saying that you could put teeth back in. Is that true? I said, yeah. Where's the tooth? He said, I don't know, I'll find out. So he called the dentist, and the dentist said, I think I have it in the drawer. And he found the tooth in the drawer, and the patient brought it over, and this is what it looked like. Okay, now, this is before we wore gloves, by the way. Look how shiny that is. Is it worth doing that? Or are you going to say, forget it? As far as I'm concerned, it's always worth it. The worst that could happen is it won't work. But we're never going to learn anything new unless we try new things. So that's part of you being a professional, is to try new things, learn new things, always be a lifelong learner. This is the way the patient looked. That's healing already after the weekend. That's not much of a socket. That's not like the kid who was in the fight where it just happened. So this is something we could take our time, because it's been out for 3 days. Another half hour, an hour won't make any difference. What we did here is we really didn't have to clean much up, except I irrigated the socket. I irrigated up into the socket to try to break up the clot without scraping the walls of the socket, because maybe there was some periodontal ligament fibers still up there. I anesthetized the patient, by the way. That's definite. This tooth we soaked in sodium fluoride for an hour before we did anything. We went ahead and did other things, put that tooth back in. It stayed in for about 6 years.
What about doing root canal?
Yeah. Well, as a matter of fact, I did it before. I usually don't. Usually we put the tooth back in. And now I'm remembering back. I did it, yeah. We did the root canal and then put it back in. I still tried not to touch this, but it looks like a lot of people had touched that. It was shiny. I don't see any periodontal ligament on there. But we did the root canal, put calcium hydroxide in the root canal. Okay, didn't fill it with gutta percha, because in those days we were using calcium hydroxide for everything, but soaked it in the sodium fluoride. And I don't know if it was because of the sodium fluoride or not, but it lasted 6 years before he lost support and it came out. But the thing is, if this patient, I think he was about 16 at the time, and if he kept it for 6 years and then he's 22, he can get an implant. So I think we did a good service for the patient. Instead of relegating him at 16 to an implant, and they weren't going to put one in because he's too young for an implant. So implants are great, but especially with kids, we have to try to keep their teeth as long as we can. Okay, let's go back to our other patient, the one who got in the fight. I think his name was Michael, I'm not sure. Michael or Mark. These are what the radiographs look like, or at least this is the first one. Always take a radiograph before you replant the tooth, unless the person put it in themselves. But if you have the tooth out, take a radiograph, because you want to make sure that there's nothing in there. You want to make sure that there's not a piece of metal in there or a piece of bone that's going to block the tooth from going all the way up there. So always take a radiograph. And then once you put the teeth in, take a look to see that you don't have any big gaps here, because you want to make sure that you're putting it in the proper space, that it's all the way up there. With this boy, it had just happened within a half hour. We told him to come right over. He came right over. He didn't have to be anesthetized. With all that work we did, he didn't have to be anesthetized, because when you put this in slowly and it just happened, he doesn't have a firm clot forming, so it is not going to be a lot of pressure. You could put it in slowly, and that patient is able to tell us when it's in position. And it's sort of amazing that you put it in, sometimes, oh yeah, that feels right, that's where it should be. So if it just happened, don't anesthetize him, just do it very slowly. So that's how it looked. Here's how it looked photographically. You could see everything looks like it is where it should be. Okay? And then, what do? We have him bite on a cotton roll. Okay? Now, we put these teeth in, reposition two of them, put the one that was avulsed in there. If you don't hold the teeth up there, they're going to slowly work their way out. So you want to have them bite on a cotton roll, at least for about 10 or 15 minutes. And then take the cotton roll away and see if it's going to change position. Okay? So that way it'll take. So that's a very important part of this. Or you could sit there with the patient and hold it up there with your finger and get indentations in your finger. It's easier to do it with a cotton roll. Okay, there are different ways to splint this. We've talked a little bit about splinting, but not really enough. So I'm going to give you a splinting chart. But if you take a look at this, here's one that the orthodontist did. Here's one that the oral surgeons did. Oral surgeons love to put arch bars on. Endodontists like to take arch bars off. If the patient has a fracture of the jaw, then leave that arch bar on. If that arch bar was only put in there because of an avulsed tooth, take it off. It's going to do damage. But if you're going to take it off, call the oral surgeon. Talk to him or her about it. Don't just do it unilaterally. You know, you're working on the same patient, you should be consulting with each other. What you want is you want the patient to be in function. What they discovered is that if it's too firm, you're not going to get periodontal ligament attachment in these teeth. You have to have some sort of function. If it's too firm, sometimes periodontal ligament fibers will go in an arch instead of at angles, and they won't connect the bone to the tooth. So it's important to have function. So with that said, here are a couple that were done in the OR. This one with just composite, and there was a little bleeding that got in here, but just composite. This one, there's a big gap here. So I didn't happen to have any wire with me, but in the OR they had a paper clip. So this is a paper clip. I took a paper clip, and then I have a kit of composite that I always used to bring to the OR when something like this happened. And I should have had wire in the kit and didn't, but you could improvise, and here we have it held in with that paper clip and bonded composite. And that worked fine, and the patient was able to have contact on that tooth. This is an interesting one, and they don't have this material anymore. This patient had a class 2 protrusive bite, you know, a big overbite. And when he bit down, there was no contact at all. So how could we build up some sort of contact so he could have function? Well, this is something they used to have called a periopack. And the old people with the gray hair remember anytime periodontists did surgery, they used to put this periopack all the way around to hold the gingiva in place, and they don't seem to do that anymore. But this was one that came in a jar, and you wet your hands, you rolled it up, you put it over the tooth, and then the wetness would get it to set. Well, this was great. We built it up, told the patient that this was like a cast on his arm, and he was thrilled. He loved this. He's wearing a cast. He wanted to know if he could have his friend sign it. I told him absolutely not, because I was afraid they'd dig a pen into it and pull it out. With avulsion, you should do endodontic treatment in actually 7 to 14 days. 10 days is ideal, because you've completely disrupted the blood supply in there. You know you have infection in there. Who knows where that tooth fell? You're going to want to make sure the patient is up to date with their tetanus shots. Nowadays, we're not giving them antibiotics for the most part, because the body is able to handle this. We're keeping away from antibiotics unless it looks like it's definitely getting an infection. So 10 to 14 days is when you're going to leave the splint on and take it off, and then the tooth should be firm enough that you could put a rubber dam around that tooth and do the endodontic treatment. We used to put calcium hydroxide in to prevent resorption when we did it. Now we're finding out that the calcium hydroxide not only doesn't prevent the resorption that much, but it causes the tooth to become more brittle and can fracture easier. So don't put calcium hydroxide in, just do the endodontic treatment. And you're going to find a lot of endodontists disagreeing with you, but that's what Dr. Andresen is talking about now. And remember what I said yesterday, 50% of what I'm telling you is going to be wrong? Well, we're having a conference in November with the pediatric dentists and the endodontists, and we're going to be discussing all this trauma business, and everything I'm telling you might change in November. So stay tuned and look at the Journal of Endodontics. We're back to this patient. He came back a year later. He had to have endodontic treatment on 3 teeth. This is the one that was avulsed. This is the one that was intruded, the lateral luxation, and this one was fractured. And this composite buildup, for whatever it is not radio opaque. But look at this gingiva. Besides the fact that this patient has lousy home care and doesn't know how to brush his teeth and doesn't brush his teeth, something like that shouldn't happen. So that's called degloving. I don't know why it's called degloving. Nobody's explained it to me, but there's been some articles on degloving. And it happens sometimes, even sometimes patients with good home care, but he had lousy home care. It's very easy to treat now that we have chlorhexidine. In the old days it was tough because you had to clean the teeth off thoroughly and have the brush very gently and have them come back and clean it again and again. Now with chlorhexidine, you could recommend the chlorhexidine and make sure they rinse at least twice a day with that, and it'll clear up very, very fast. Here he is, 3 years later. He was getting a crown on that tooth. Everything seems to be going okay. 13 years later, he's playing basketball and got an elbow into his tooth. And look at that. Okay? But that stayed for 13 years. We did a service for that kid, even if he wasn't too compliant. So we did a service. Please, guys, don't put in posts like this. These posts are horrible. They're going to fracture teeth. You have to have at least 5 millimeters of gutta percha, which you don't have. But that's not the problem. This is the problem. That had a a shorter post. Okay, and finally, we want to look at the fracture of the alveolar process. That's when the bone is broken and maybe the tooth is moved a little bit. That you could replace, but people get worried about what you do about the alveolar process. And that's another simple answer. Nothing. Okay? We're going back full track. Once you put this back into place, and then possibly splint it because of the tooth, the gingiva is going to hold that alveolar process in there. That's going to act as your splint. That's going to act as your cast. And the bone will actually heal very rapidly in a situation like that. So you really do nothing with the bone itself. Okay, this is something you should try to remember. Again, it's going to change. But this is a summary of splinting for a root fracture. You remember the kid at the beginning who had the root fractured, and we put it back in and we splinted it? 6 weeks for a root fracture. Extrusion and lateral luxation, 3 weeks. The root fracture needs to be splinted twice as long as the others. So do that. And for the avulsed teeth, which you would think would need to be splinted the longest, is actually splinted the shortest. And that's only 1 to 2 weeks, because then you're going to do the endodontic treatment, and it'll take from there. These are the numbers from the latest research, and like I say, it may change. And I suspect it will. We're going to find some new research coming out at this meeting that's going to give us numbers. But that's something to keep in the back of your mind, and just see how that's working. Okay, I told you we're going to finish up early. This is the locker room for the Miami Dolphins. That's when I had dark hair and was a little thinner. And there's just something I want to leave you with. The way people were before, I figured we'd speed this up a little bit. Hopefully you got something out of this that you could use for a long time. It's been great being here again. This is my 3rd time here. I've enjoyed it immensely. Thank you to Dr. Alfaro and to the endodontic faculty, especially Dr. Mata, who's not here. He probably went home to take a nap. It's been great. I love your school. I love your country. It's been fun being here. And just enjoy your new school. It's going to be great. Those of you who are graduating before it's built, sorry. But make sure you send your contributions into your alumni fund to support it getting even better. Because when you graduate from a great school like this, it adds to your credentials. So again, have a great weekend, and thank you.